Classification and definitions in orthodontics. When an orthodontist looks at a face, they don't just see teeth, they see relationships between bones, muscles, and the bite that holds them together. Every diagnosis starts with classification. The language of orthodontics. In this lecture, we'll break down how we classify the jaws and teeth, anteroposteriorly, vertically, and transversely. By the end, you'll be able to read a face like an orthodontist, from skeletal balance to smile harmony. Extraoral skeletal pattern, anteroposterior. Let's begin with the anteroposterior relationship, the front-to-back balance between maxilla and mandible. Class 1. Orthognathic pattern. The mandible lies about 2 to 4 millimeters behind the maxilla. The profile appears straight or slightly convex, balanced, harmonious. It's what we call a normal skeletal base. Class 2. Retrognathic pattern. Here, the mandible lies more than 4 millimeters behind. The profile becomes convex, the chin retrudes, lips may struggle to meet. It can result from a small mandible, a forward maxilla, or both. Clinically, we often see an increased overjet and deep bite. Class 3. Prognathic pattern. The mandible is too far forward, sometimes even ahead of the maxilla. The face turns concave, the chin dominant, the bite reversed. It may reflect true skeletal excess or dental compensation hiding a skeletal discrepancy. Vertical skeletal pattern, FMPA. Next, the vertical dimension measured by the Frankfurt mandibular plane angle, or FMPA. In an average facial type, the Frankfurt and mandibular planes meet at the back of the skull, the occiput. Facial thirds are proportional, muscle tone balanced. When the FMPA increases, the planes meet in front of the occiput. The mandible rotates clockwise, the face lengthens, we see an open bite tendency and weaker elevator muscles. When the FMPA decreases, the planes meet behind the occiput. The mandible rotates counterclockwise, producing a short face pattern, deep bite, and strong musculature. Think of the mandible as a hinge. Swing it clockwise for a long face, counterclockwise for a short one. Transverse symmetry. From the front view, we evaluate transverse symmetry. Draw an imaginary vertical line from the midpoint of the eyebrows through the nose tip, upper lip, and chin point. If they line up, symmetry. If not, asymmetry, which may be skeletal, like a deviated mandible, or dental, such as a crossbite. Soft tissue profile and smile. Soft tissue analysis completes the picture. The nasolabial angle between the base of the nose and upper lip averages 90 to 110 degrees. An acute angle suggests a protrusive maxilla or upper lip. An obtuse one. A retrusive lip or flat midface. Lip competence means the lips meet naturally at rest, while incompetent lips require muscle effort, often in vertical maxillary excess. During smiling, we distinguish a posed smile, deliberate and repeatable for clinical photos, and a spontaneous smile, emotional and maximal. The smile arc is the gentle curve of upper incisal edges following the contour of the lower lip, the hallmark of youthful aesthetics. TMJ and functional positions. Let's move inside the joint, the temporomandibular system. Centric relation is the joint's purest reference, the condyle seated superior and anterior in the fossae. It's independent of tooth contact, repeatable, and stable. Rest position is the relaxed state. Minimal muscle activity with a 2 to 4 millimeter freeway space. When a tooth touches prematurely on closure, the mandible may deviate to find contact. That's a premature contact leading to functional displacement. Over time, these small shifts can cause TMJ discomfort or asymmetric wear. Incisor and molar relationships. Now the dental side, starting with the incisor relationship, defined by the British Standards Institute. Class 1, lower incisor edges meet the cingulum plateau of the upper centrals. Class 2 Division 1, upper incisors proclined, overjet increased. Class 2 Division 2, upper centrals retroclined, deep overbite, small overjet. Class 3, lower incisors ahead, reverse overjet. For molar relationship, we follow Angle's classification. Class 1, the upper first molar's mesiobuccal cusp fits neatly into the lower molar's buccal groove, the ideal. Class 2, that cusp lies anterior, a distal occlusion. Class 3, it lies posterior, a mesial occlusion. Remember, Angles classification describes dental alignment, not skeletal position. Overjet, overbite, and crossbite. Overjet is the horizontal gap between upper and lower incisors, normally 2 to 4 millimeters. Overbite is vertical overlap, ideally covering 1/3 to 1/2 of the lower incisors. Too much overlap, a deep bite. Too little, an open bite. When lower incisors lie ahead, we have a reverse overjet or anterior crossbite. In the posterior region, if lower buccal cusps sit outside the uppers, that's a buccal crossbite. If they sit inside, it's a lingual or scissors bite. Alignment and spacing. Dental alignment reflects the balance between tooth size and arch length. Crowding occurs when the arch is too small to accommodate the teeth, leading to rotation and overlapping. Spacing is the opposite, excess arch length. A midline diastema, especially between upper centrals, is common in early mixed dentition and often self-corrects. Impaction happens when a tooth fails to erupt, usually due to crowding or obstruction, common with maxillary canines. Supernumerary teeth, such as a mesiodens, add further complication. Bolton discrepancy measures mismatch between total tooth widths of upper and lower arches, critical for finishing stages. Tooth movement and anchorage. Every orthodontic force creates an equal and opposite reaction. That's why anchorage matters. Intermaxillary anchorage uses both arches, like Class II elastics. Intramaxillary anchorage stays within one arch, like a transpalatal arch or lingual arch. Types of movement include tipping, crown and root opposite directions, bodily movement, both move equally, uprighting, correcting angulation, torque, buccolingual root movement. The moment of force describes the tendency to rotate. The centroid, roughly 1/3 from the root apex, is the tipping center. After treatment, teeth tend to drift back. That's relapse. The reason retention is vital. Orthodontic appliances. Appliances are the tools that translate diagnosis into movement. Removable appliances, acrylic and wire plates, handle simple tipping or functional correction. Fixed appliances, brackets, and arch wires provide three-dimensional control. Common anchorage aids include the lingual arch, Nance palatal arch, transpalatal arch, and quad helix expander. The 2x4 appliance, bonding brackets from molar to incisor, is ideal in mixed dentition. Functional appliances, like the twin block, harness muscle forces to guide growth. And when growth needs more, we use extraoral appliances, headgear to restrain maxillary advancement in Class 2, or a face mask to protract the maxilla in Class 3. Orthognathic surgery. Sometimes, orthodontics alone cannot correct skeletal imbalance. That's where orthognathic surgery joins the plan. Before surgery, orthodontic alignment removes dental compensation. We call this decompensation. Then surgeons perform BSSO, bilateral sagittal split osteotomy, to advance or set back the mandible. Lefort 1 osteotomy. To reposition or impact the maxilla. Genioplasty, to adjust the chin in any direction. In growing patients or length deficiencies, we may use distraction osteogenesis, gradually separating bone segments at about 1 millimeter per day, allowing bone and soft tissue to regenerate together. Functional occlusion. Functional occlusion describes how teeth contact in motion. The working side is the direction of mandibular movement during chewing. The non-working side is the opposite. Canine guidance means only the canines touch on the working side, protecting posterior teeth. In group function, several posterior teeth share that load. Non-working interferences are unwanted contacts that stress the joint. Disclusion is the natural separation of teeth during movement, an essential protective mechanism. Growth concepts. Growth influences everything we've discussed. Growth rotation, clockwise or counterclockwise, changes facial height and mandibular plane angle over time. And according to Moss's functional matrix theory, bones don't grow on their own. They respond to functional demands of the surrounding soft tissues. The skeleton is a servant, the soft tissues the master. Conclusion. Classification is more than a list of terms. It's the map that guides every orthodontic diagnosis and treatment plan. Once you can classify, you can diagnose. And once you can diagnose, you can treat with confidence and precision. Thank you for watching.